Welcome to the Dental Tutors podcast with your host, Cornay Smith and Adnal Koch.
This is an honest conversation about the questions we all have but might be afraid to ask.
Both on clinical dentistry and topics that go beyond the dental chair.
Join us as we navigate this growing field of dentistry together. In today's episode, we will be chatting with our friend and colleague, Dr. Blackie Swart, a maxillofacial and oral surgeon in Cape Town, South Africa. We will be discussing the TMJ and TMD. It is one of the most overwhelming and complicated topics in dentistry for the general dentist. We will be discussing Dr. Swart's approach to diagnosing and managing this multifaceted disorder holistically.
Thank you so much, Blackie, for joining us today. We really appreciate your time. We know that it's valuable, and it's such an honor and privilege to chat to you today and to get just more knowledge about a grey area in dentistry, which is the temporomandibular joint. And I would love for you to start us off today by just looking at the baseline of how do you define temporomandibular joint disorder or disorders?
I think that the first is that anatomy is most important, and of all the different areas that you go into dentistry, your clinical examination and history taking is most important in temporomandibular dysfunction, identifying temporomandibular dysfunction, because there's a huge difference between TMJ and dysfunction and TMD itself, because TMD is really defined as the the joint itself, that is the capsule, the meniscus and the bone itself, and then the muscles of mastication, and the third leg of that is the pains associated with those muscle pains that you can have. So really the crux of it is that the newer definitions of TMD is moving away from the occlusal component of that, although I think it is highly important. It's very important.
Okay, so you're talking more about a group of disorders.
Yes, there's more than 30 disorders in the temporomandibular dysfunction group itself.
So then the correct way of really talking about it is talking about it as a dysfunction and not as a disorder.
Yes.
And then to really specify which disorder we are looking at when we start looking at diagnosis. Am I right?
Yes, absolutely. And I still define there's three components that affects TMD. So to me, it is the muscles of mastication, and that is the most obvious one that we see. And after COVID, it's more prevalent. I think because of the link that it has to anxiety and depression, and these muscles of mastication is really the workhorses of your face, because it's not only chewing, it is also every time you swallow, every time you talk. So with all muscles outside of the facial muscles, you can isolate it and you can save it and you can splint it for a period of time. But the muscles of mastication, even with intermaxillary fixation, the muscles still function when you swallow, and you swallow about 720 times a day.
Wow.
So that's the first component, is the muscular component. And one thing that we can start off with, and which I always find, is when patients come in, they come in with a molar problem, and they say they've been to many dentists and it's this molar, and they would show that exact molar to you that is painful. And yet, if you ask them, is it painful on functioning, they deny that. And the more you start asking the question, but is it inside the mouth or is it outside the mouth? So that to me is a classic indicator of muscular problems, is if the patient is showing towards the outside or towards the inside. And for you as dentists, it's very easy to determine those two, because all you have to do is put your finger inside the mouth, because As soon as you get into the buccal mucosa, you can actually palpate the muscle on the outside and the tooth on the inside.
Yeah.
So thereby, just by that simple technique, you already defining 50% of your cases of TMD.
Wow.
So that's the muscular component. And then we go into the joint itself. Now that is pain that's often presented is a capsulitis with pain on the capsule itself. And then obviously intra-articular changes. And that is if the disc is displaced, if there's a clicking or popping noise, or if it's anterior displaced. The take-home message is the pain fibers are only situated in the posterior ligaments. There's nothing in the medial or the anterior of the disc. So only once it starts pulling out and get dislodged do the patients have pain in the ears. And then the third is the headaches or the related pains to the temporomandibular joint muscles, the muscles of mastication, and that obviously can be referred type of pain.
Yeah.
And what type of radiographic imaging do you make use of to diagnose TMD? Do you have a gold standard? Do you only use PANS? Do you use CBCT, MRI?
I think that's the biggest problem that we have. The first thing is not an image, because an image there's no golden standard of an image that can say this is TMD. It does not exist. So here we've got to go back to university and go back to medical history taking, because the time that you spend on taking the history, that is the time that you can make your diagnosis. A diagnosis on radiograph, I do not find the Panorex very accurate. What I do find is the CBCT of a temporomandibular joint itself for degenerative type of diseases. Yes, then it's good. You can either have a CT or CBCT. I really do it frequently to eliminate degenerative joints. But remember, we have now, from an introduction, we've really jumped to an end conclusion, and there's a lot of material and a long way in between before we get to the image. So your first thing is not your patient comes in with a TMD, I'm going to take an image and I'm going to get an answer. The thing is, you've got to go through all your medical history, all your conservative treatments, and then you get to your imaging. And the imaging most appropriate is for hard tissue, is a CBCT in my opinion. And if you want to know what's going on with a disc itself, it's an MRI study. That's the only conclusive imagery that you can have on the TM joint.
So basically what I'm hearing you say is we've got this kind of group of patients that we see very often, and it's very interesting that you say that they're more prevalent after COVID, because we know that these disorders are also related to anxiety and stress. But these patients come in with certain symptoms, headaches or pain on the outside of a tooth or on the outside of their face, muscular pain, popping or clicking. What are the tools that you use then? What is your system? Do you go through a medical history, extraoral exam, intraoral exam? How do you approach this?
Absolutely, that's the most that's an excellent way of how I approach my patients. So the first is your medical, the background. What is the main complaint? So you find out what the main complaint is, and then you ask about the nature of the pain, the duration, the type of pain that you have, the position. Does it, in which frequency does it come? Is it more prevalent in the mornings, in the evenings, during the day? And then after I've established the pain itself, then the first thing that I do is I want to know, is it a functional problem or is there a different type of problem? So, and most of that, if there's a TMJ now, we're going to the joint itself. If there's a problem, they would have a problem in opening the mouth. And when I open, I know it is not a scientific way, because I like to just let the patient first thing open your mouth and see how many fingers you can get in. It's not as precise scientific evidence. I know there's been some criticism about that in literature, but that gives me a very good indication, because if the patient sits in front of me, whilst he's opening his mouth, I'm observing much more. I'm observing his occlusion. I'm observing if there's any deviation or not, and I can then see if there's limitations of movement. That's my first question. The second question that I ask is there any foods that they avoid eating? Because that can show to a dental problem, either a specific tooth or a muscular group problem. Then going further into that, I go into habits. Do they have any habits? Like, for instance, biting your nails, or eating, or putting a pen constantly in, or just actively, a lot of patients would just move their jaws forward. Any constant movement forms pain in the end. So that gives me an indication where they're going. And then if they've been involved in a motor vehicle accident, especially, I'm looking for whiplash injuries. I'm looking for post-traumatic incidences. And you can also eliminate the patients that are just here for the sake of putting their minds at ease, because about 60% of patients has got a popping or clicking noise in their joints, and they're worried about it. But as long as it's not painful, it's absolutely no problem. They just want to know what is the problem, and if you can show them on a video what this dislocation looks like, then it is all good, and the patients are happy. Then obviously I ask about clenching habits, and you get two different clenches. You get the clenches that is hard, where teeth actually move over each other, and the silent grinders. And with myography tests, the silent grinders are actually worse than the hard grinders that wake their partners. And for me, an interesting thing is, obviously, with sounds, you want to know crepitus as well, because crepitus is cartilage on cartilage. Okay, that's dangerous. So that already puts up a red light to me. And then another thing that's interesting for me is how do you sleep? Because a lot of my TMD patients sleep on their stomachs, and then with the force of your arm on your chin, it is forced in a certain direction. So it is highly significant how many people sleep on their stomachs with TMD.
Sure.
And then obviously, stresses. My son has just gone through it. He's writing his final exams, and he came in here with acute TMD, but because of clenching. So
makes sense.
So that is basically a rough medical questionnaire that I follow, and then certain areas where I pick up there's a problem, I will obviously steer in that direction to get the correct answers from them.
Yeah, and you briefly touched on what crepitus is. Can you discuss the anatomy of a click in the TMJ?
The best is on a video. I've got some excellent videos which I can share with you to show. But the disc itself is a bilaminar disc with a concave center. And that concave center, when your jaw is in resting position, the concave must be above the condyle. But invariably, it does not sit there anymore, because if there is pressure from clenching, that meniscus moves to the anterior. And therefore, if you then want to open the mouth, it first the joint, the condyle rotates before it translates. And in that rotation, the disc is brought forward, and then you get a thickened, almost like a scar tissue. And it's got to bump over that click to go forward. And if you have really had a night of hard clenching or days of hard clenching, it's like two pieces of glass that you put together with a few drops of water in between. It's very difficult to open it. But if you rotate or translate the joint, then it is easier to open. That is the classic patients that come in, they say, my jaw stuck, I couldn't open it. And that is that first rotation against this fibrous tissue, and they couldn't open it, and everything feels stuck. It's because of this glass type of reaction. Wow. And as soon as they move their jaws, they say it feels free. And obviously the next stage from there, and that is the dangerous stage to me, is once they start opening and then they force it in this rotation. And as they force it, they tear it out of the back. Sure. And remember what I said, the pain fibers are situated in posterior. That's when they have that sharp shooting pain. And then after it's torn, now you've got an anterior displaced disc. Now there is a possibility of cartilage on cartilage movement. So for those patients, you've got to have a bite plate in between the occlusion as soon as possible, and I let them wear that for 14 days on a row, because now your chances of going to an arthritic type of degenerative joint, which is the last and final stage, is higher, because you've got this cartilage on cartilage. And we talk about mice, the mice in the joint itself. So that's the progression of temporomandibular joint dysfunction.
That makes sense. And I mean, it's definitely something that we see very often in our practices. When we start examining patients, if you spend enough time with patients, if you're in practice for 10 years or 15 years, you can see how this is getting worse. And where patients would have maybe just a mild click at some stage, where it would progress into something that becomes a lot more prominent. Do you find that this is something that's more prevalent in men or women? Because I have a gut feeling about that. I would love to hear what your take is on that.
I just know what the science says.
Yes.
It's more prevalent in women.
Absolutely.
And they are at the moment doing studies to see if it's the anatomy or it's the occlusion. But in my opinion, it is because we are expecting so much of women, and women multitask, and the way that I see it, it's like a duck. You know, a lot of women, it is expected of them to have a very good exposure towards the outside. Well, it's the feet underneath of scrambling like that. And I think that factor, I'm not saying that it's only women that would be affected by that, but it is scientifically proven that women has a higher incidence of TMD than men.
That's very interesting, because that's definitely what I see in practice as well. Something else that I heard that could be contributing to this, I'd love your take on this, is that because of the actual structure of the joint and the bones, we obviously more prone to arthritis, and maybe that could be a potential cause, where in men we see the destruction more on their teeth, and in women we see the destruction in the bone. Do you think that plays a role at all?
Yes, but I would like again to take you a little bit back. Remember, if you take any joint in the body, there's none so complicated as a TM joint. If you think that a TM joint can rotate, it can translate, it can also translate to the left and to the right. So it is a highly mobile disc in all aspects and in all directions. There's no other joint that can do that. And if you can think of the forces per square inch of the masticatory muscles, where we are allowed to, or we can crush a nut between our teeth. Show me any other joint where you can put a nut and you can crack that.
That's
It's
a good
not
point.
possible.
Wow.
So these muscles work in a tremendous tension area, and yet we have so little problems. So actually I think that we are really blessed not to have so much muscles, and that's why it's so important, the movement itself. So the structure of the joint, yes, and maybe I have got no scientific or conclusive evidence. I agree with you, but there's no science behind what we are saying.
Yeah.
On men and women. What it is, it's just open at the moment, and all of the information that we have is purely discussion.
Yeah, I understand what you're saying.
Yeah, I sometimes find it difficult to even communicate periapical pathology to a patient. So you're saying TMJ is this difficult.
TM joint, you know, and TM joint is one of the most difficult things. And let me get to my pet hate. And my pet hate is one of the first treatments for temporomandibular dysfunction is an anterior displaced biplate, so that you can release some tension in the posterior. But it is only for a short
time.
period of time.
Okay.
And now these biplates that are sold at exuberant prices is a constant placement of the mandible in an anterior repositioned place. And you get, if you then study these x-rays, CBCTs, very carefully, in a patient that's been, I've seen it often, there's no scientific evidence, but I've seen it often, where the condyle works against the eminence and you get erosion of the tooth because of this biplate. And I see lots of these biplates coming in. They are indicated only for a very short period of about 4 weeks. Then you've got to step back and you've got to have a level plane occlusion plate.
Yeah. So that's something that I really want to dig into is talking about bite plates. But maybe before we get there, can we look at how you decide whether a patient actually needs one? Is it for everyone? And how do you look at your approach with your treatment protocols, such as maybe physiotherapy or Botox therapy? How do you approach that?
Okay, my approach is simple. If a patient comes to me, I say, this is an incurable disease. If you want to know about an incurable disease, TMD is an incurable disease. But if they are, and the way of managing a TMD is like an S-curve of a graph, an S-curve. So all you do with your treatment is you shift the horizontal line of when a patient is going to experience symptoms or not. So one of these modalities is to use a biplate. Okay, so the patients that come to me, remember, they've often been to their dentist, they've come to the end, they really, they are in deep trouble if they come and sit here with a TMD. So I go in boots and all for the first examination period, and I enhance the patient's knowledge by explaining them the anatomy of the TM joint and the muscles itself, and how the old name MPDS is actually more descriptive to me. It's myofascial pain dysfunction syndrome. So it's not only the muscles, it's not only the joint, it is the fascia as well. And so that is a very descriptive way that is now gone by the way. Because of scientific reasons, I can understand it, because you're just too wide with MPDS. But what I do is I go for try to stop the inflammation as much as possible. And we know that the fluids in the upper joint space is only about 1.5 cc's and the lower joint space is 0.75. And for the fimbria to get the inflammatory mediators out of the joint takes a lot of time. And it goes slowly. So for that, I give a Voltaren suppository for 3 days. Okay, a high non-steroidal anti-inflammatory, and then I use Celebrex for at least another month. It might continue a little bit, but that's my first step. My second, which I think is just important, is I have got a very good relationship with physiotherapists, and they do all my patients. So they immediately get a physiotherapy appointment. And thirdly, if it's indicated, and most of the cases I think is indicated, is just to give the muscle, because masticated muscles just need to be released a little bit, so that it's not directly into occlusion. We're taking it broadly. I mean, there's certain things about occlusion that we've got to look into detail, and it's obviously not a quick consult if you do it. So I give my patients a bite plate in the upper jaw. I know there's some that prefer the lower jaw, but I prefer a normal, traditional upper jaw bite plate. And I determine by the patient's bite and profile how much I want to open it. And at the moment, I have it digitally made. And the digital material for me is actually very nice. I get a very good return, and it is thermoplastic. So if I then want to adjust that, just that little bit where it's too tight and acrylic, you really have to go and try and clear it. With the thermoplastic, you just put it in hot boiling water for 2 or 3 seconds, and you put it back, and there was no distortion of your bite plate, but it's relaxed a little bit. So that is my approach to a TMD. Then I would carry on with this treatment for a minimum of 3 months before I even consider doing anything else. So the bite plate that I use is not a treatment tool. It is a diagnostic tool, because I use that to diagnose, and I would open and close that bite until that patient is symptom-free. If the patient is not symptom-free within the 3 months, we've got to look at all the different alternatives. And let's put the ball where you want it. What do we do with Botox? I myself do not inject Botox. The reason why is I do not want to come to the office and that people line up from the passage there all the way here so that I can inject them Botox. And I also feel I can make an objective decision of when my patients need Botox. I only use one dermatologist, Isolde Heidenrich, I'm allowed to say the name, and she does all my Botox injections. But it does come at the end. It's really, in my position, I think it is doubtful for a dentist, unless you treat a lot of TMD, to send somebody for Botox. It must go to at least a specialist or somebody that deals with TMDs, because there is obviously general practitioners that spend a lot of time and has a lot of knowledge on this. Yes, and if they are sure that it's the TMD, the muscular component, then obviously the end, if it does not respond to normal conservative measures, that's my point, must not respond to conservative treatments, then Botox works. And yes, if on those patients that I've chosen is a high degree of success.
Yeah.
But they must be in your indication must be correct.
Yeah, and then going back to medications. We'll come back to Botox, I would love to. But going back to medication, in your consult, you establish that just hypothetically speaking, I'm one of your patients, and you establish that I have gastroesophageal reflux disease. How does that change your prescription how does that change what you would prescribe for the patient in terms of your non-steroidal anti-inflammatories?
Obviously, if you have a real problem with GERD, then anti-inflammatories are contraindicated. Also, patients that's allergic to them.
Yeah.
And now we find more and more patients, even in the preservative, in the composition of non-steroidals, which they use to bind it. I've had some allergies recently to that, which is quite infrequent. So for them, obviously, you've got to look at alternatives. And obvious alternatives that one must not forget is heat and cold. Compression packs, heat and cold, that is a position that you can take. And even one of the superficially applied non-steroidal anti-inflammatories like Transact also. It doesn't work so well on the temporalis muscle, but on the masseter muscle it works wonderfully. So, and then you don't have the problem of GERD and it being influenced by non-steroidals. So there are some absolute contraindications, but there's a lot of cases that you can use a milder type of anti-inflammatory as Celebrex that is used for rheumatoid arthritis patients on long term.
And something like orphanedrine in Norflex?
I haven't got much experience, so I cannot answer that.
Okay.
Yeah, but I mean, it would probably give you the same results, because it would definitely give relief, I think.
Yeah.
But I don't think that it's something that you would use for the long term. Yeah.
You want to use something that you can use on a longer term, because TMD is not a thing that is cleared after 2 to 3 days. It takes at least 3 months before we make the second decision.
Then a completely different side of this disease is that there's a psychological component to it. How do you approach that when you have a patient sitting in front of you that there's some muscular pain, and there's definite maybe if you look at the joints, there's maybe some symptoms on the joints as well, and the patient could be in acute pain, but we know that the cause or what's making it worse.
It's very simple. It's really simple.
How do you approach that?
You look who's your best opponent in your industry, and you refer them to them.
Oh my God! Yeah.
No, it is a real difficult one, and there are some people that just can't get over that psychological barrier. There are a lot of there are some patients that I treated that once they understand the problem, most of them are satisfied, and a lot of them think that they've got a brain tumor, especially if on the temporalis. They come in and they have this absolute phobia of having a brain tumor, and they're sure they have a brain tumor. And then if you elicit the pain in the bundles that are in spasm, they suddenly, it's like a light bulb going open for them, and they realize, but suddenly I'm with somebody that takes the time to explain to me what the team joint and the muscles are all about. And then they understand that, and they go out with a big smile. That's the happy ones in the practice. One of the more interesting ones that I had was a music teacher, and she could not get a pitch, a certain pitch. And when we did the CBCT of the joint, the distal bone to the eardrum was extremely thin, and the meniscus was pressed against it. And we gave her a bite plate by just opening the bite and giving a little bit of release in the joint itself. And suddenly she could examine her musical graduates again.
Wow.
So she still comes to me after years. I mean, she's been wearing a bite plate, and that is because of an anatomical discrepancy that she had. So that was
very interesting.
yeah, that was just one of the more interesting things I had in my life.
Oh, wow. Sheesh. We're having a great time.
No, I mean it is really interesting. I find that it's one of those disorders or the type of patients that you see more of when you understand the disorder more. You're much more aware of how patients are sometimes really suffering. And I find that it's very useful to take a very simple approach. So I love what you're saying about utilizing a physiotherapist. We also have an amazing physiotherapist in our area that we often work with that understands the TMJ. And taking it slow with the patient, which can make it easier to then also manage the psychological component of it, because very often that's just associated with anxiety. So to jump into this and to make it, this big thing, sometimes can create even more anxiety.
And obviously your referral to a psychiatrist for these patients are often groundbreaking. Because they go through their lives and nobody wants to tell them, but please go and see a psychiatrist. And in the end, when you identify the patients that you see has really got a psychological problem, and you refer them, it's like they don't want to believe you at first, and they might not go to the psychiatrist after your referral. But you've put something in motion so that they realize it's not a physical thing, because the psychological patients, they want you to tell them, listen, I'm going to do a root canal treatment on this tooth, or I'm going to pull this tooth. And that's absolutely the wrong things. I think many a root canal treatment or filling or extraction had been done, which should have been solved by good understanding of anatomy and the problem itself.
Oh, wow.
So true.
Yeah. And then obviously touching on that, what would you say is the common misdiagnosis or even differential diagnosis of TMD that you see very, very commonly? Because sometimes this is it's a multidisciplinary approach, but sometimes it's unintentionally multidisciplinary. So the patient sees an ENT, from the ENT they go to the dentist, from the dentist they maybe go straight to the physio, from the physio they come and see you, maybe they go to a dermatologist or to a plastic surgeon to get some Botox first. So what would you say is the most common misdiagnosis and differential diagnosis for TMD?
The most common that I see in my practice, and that is at least 1 in 3, is antibiotics for ear infections. The lot of general practitioners the patient would go with pain, and they would hardly look in the ear, or they would even tell the patients, listen, I don't see anything, but it must be an antibiotic. And that's absolutely the wrong approach. So many of my patients that I see has been on a minimum of 3 courses of antibiotics, and the pain does not disappear.
Wow.
In the group that I'm in now, the ear, nose and throat specialists appreciate that, and they realize that they should not put them on antibiotics, and I get those referrals a lot. So that is by far the most common misdiagnosis that I find. But on the other hand, otitis externa can be very, very painful and can mimic TMD. So you must be very careful before diagnosing TMD if you haven't excluded otitis externa. And the way to do that is to lift up the ear by the angle. And if you pull that and the patient has pain inside the ear, you must have an ear, nose and throat referral. So from the dentist to the ear, nose and throat specialist, because it can mimic itself as a masseter pain.
Yeah.
And the patient has got pain and they might be clenching because of the pain.
Yeah.
But it is actually an otitis externa or media. So yes, be careful of your diagnosis. So my whole, how I see it is, I'm not saying don't do this, don't do that.
Yeah.
I say be careful before jumping into a conclusion and
Yes.
convincing a patient of a certain thing.
Yeah.
Be very sure and take your time before you get there.
Yeah,
Oh,
that's
wow.
very true. And when you see this disease progress, or when you see people with real end stage degeneration, do you still often do surgery?
I don't do surgery of TM joints anymore. We had our training. We did a lot of TM joint surgery, and most of the TM joint surgeries has an improvement of symptoms of only 60%.
Oh, wow.
That means 40% of the patients are worse off than
Wow.
what they started. That excludes end-stage surgery, so end-stage disease. So your question was a little bit tilted in my side. So I'm saying about dislocations of joints, clicking, temping, and mild disease that could have been treated in any other way than surgery.
Okay.
So in those cases, so the first type of treatment that you would consider is arthrocentesis. So
Yeah.
where you put the two little needles in, but it's easy to get into the upper space. But to get into the lower space is technically very difficult. And then you rinse the joint.
Yeah.
But they found that if you do it conservatively, or you do arthrocentesis, at the end of a year, the results are exactly the same.
Yeah.
And also, then we get to the arthritic type of situations, and we know of all the scientific literature of the over-treated TM joint, and the pain doesn't go away, and it's one operation on the other. The most well-known problem is the Afrikaans Annelie van Rooyen, which had TM joint surgery, and it was a total failure. So one's got to be extremely careful of surgical options. I think there's a clear indication at end stage surgery to do a joint replacement surgery. But those cases are few and far between. And it is, I think, as any specialist, it is published now, if you want to be an expert on something, you've got to do at least 52 of those cases per year.
Yeah.
So
It's one a week.
And one a week.
Yeah.
And I do not see that many patients in the temporomandibular dysfunction group that I have to operate once a week. And for those that do, they get good results with TM joint replacements because they've come a long way in getting that. There's also maybe an opening to do arthroscopic surgery because it's not open surgery, but open surgery is now not the preferred way of treatment.
Yeah, that makes complete sense. I spoke to, I'm sure I don't know, maybe you know her, Colette Smith, who's a maxillofacial surgeon. She qualified, she was actually in my year group. We studied dentistry together, and then she did medicine, and she became a max fax. So I spoke to her about a couple of TMD patients, and it was so interesting to see how the technology has changed in the disc replacements, and how the 3D printing industry, like all of that has actually made it so much easier for people to be able to have these replacements. But what was most obvious to me is that it's mostly associated with trauma.
Yeah.
It's patients that were in accidents that need these replacements. It's not the classic patients that we see in our dental chairs.
Or the ankylosis patients. Or the congenital deformed patients.
Yeah.
But we see those we do not really see in private practice.
Yeah.
They are seen in the state. Also, middle ear infections that's left untreated for a very long time with ankylotic problems.
Yeah.
Yes, for those, absolutely. And for the congenitally deformed, or not deformed, congenitally defect, where you can put a little bit of a rib with cartilage in. That I've done with great success. And to see that patient growing, aging, maturing with that rib in position, and it actually not forming a asymmetry, and absolutely growing, it being a growing center. It's really wonderful to see that. But I do not think that surgery is the first line of approach of the patients that we are talking about.
That's
because we are talking about TMD. And that I do not I do not think that the first line is surgery.
Yeah, absolutely.
And then there's another type of treatment that's quite recently, a few dentists are doing it. I'm not sure if any specialists are doing it. It's the use of diode lasers, the treatment of DMD.
I know of it only as a scientific reference, of which the papers are very skewed, and it is very small numbers, so it is not of the scientific pyramid on the top level. It's really the baseline levels that was published, so I cannot... that's the only thing that I can say. I've never seen a review study of it, and I've never seen it in an accredited study.
It's a difficult one to talk about because we can't really evaluate it.
I think I had a very different outlook on TMD, and I'm glad that I experienced this very, very early on in my career. I had the opportunity to come and shadow you back in 2020, I think. 2019,
I can remember that. You were right.
And on that day, you probably saw about 8 to 10 patients, of which 6 to 7 of them were probably all TMD. And they were all at different stages, which was great. And there was someone who was post-surgery. There was the initial consult, and I actually managed to see you go through all of that, which was amazing. With you, in that visit, you obviously referred some patients to the physio. What happens at the physio exactly?
Okay, so what you're asking, it's I know, it's what about TENS? Do we use TENS? Okay, so TENS, if you look at the muscles, it's very, if you look at the anatomy, the masseter muscles actually got 3 origins. So to put a TENS sticker on is difficult. And in the hairline, it doesn't work well. So what we do is ultrasound, physical manipulation, and also the fascia bundles. So all of the fascia, and that includes the shoulders and the neck. So we go for a more holistic approach to the TMD, and the physios use ultrasound. We have tried dry needling, and I've seen some scary stuff. I've seen some dry needling of the medial pterygoids. So what they do is they ask the patient to open and then go through the notch between the coronoid and the condyle, and they actually stick the needle right through there and needle the medial pterygoid. Now that is with the pterygoid veneers plexus right behind it, with a direct cranial access. So I got a little bit scared when I saw that. And coming back to your question on TENS, the TENS apparatus do have little crocodile beaks.
Yeah.
So if you do dry needle the muscles, especially the temporalis muscle, then TENS with a crocodile clamp can work.
Yeah.
And dry needling, the patients do find satisfaction. And one misconcept, I'm taking a little bit back to diagnosis again, is that you can actually palpate the lateral and medial pterygoids, but it's wrong. They've done a study on cadavers to see it, and it's actually the medial attachments to the temporalis, not medial, the medial attachment of the temporalis with its head on the coronoid that you're feeling.
Yeah.
And that is one of the first points that I check to see. You know, from being here, I always give a patient 5 out of 5.
Yeah.
So I go and check, and I check all the muscles. And if you've got 5 out of 5, then we carry on. And is to put your finger inside the mouth where you want to give an inferior alveolar block, and then just let your finger slide up a little bit, and you give digital pressure. And a patient with true muscular TMD jumps through the roof.
Yeah.
And you check that on the contralateral side to make sure if you are making the right diagnosis and not just pressing too hard, and that it is the muscle that is in spasm. So yes, I do believe in an intraoral examination for the muscles, but you must be realistic of what you are palpating.
Okay.
Yeah.
I have to be honest, I thought that the lateral pterygoid was the one that we were aiming for. So I've definitely learned something now. If you've done your diagnosis, I mean, just going back, I would love to just spend a little bit more time on the bite plates. So one of the questions that I have is, do you treat a clencher and a grinder? So if we think of someone that clenches down, I'm talking about someone that has, like, you know, this, they can sit in front of the computer, they can be driving, and they just have this over-exerted masseter.
They look like a bulldog.
They look like a bulldog.
Absolutely.
And we can spot those patients a mile away.
Yeah.
And we also see a lot of damage on their teeth. Versus someone that is grinding on their teeth. And that could be either audible or not audible. That is kind of more of a lateral movement, and there's a lot of, it's almost freedom in that movement. So what I have heard, and this is not scientific, but I've seen that there could be two different approaches to designing a bite plate for someone that has that clenching down pressure versus the guy that goes side to side. Is that something that you look at?
Yes, that is. The problem that I see is actually before the grinding happens. And I ask the patients, where is your tongue in normal movement? If you, not normal movement, in relaxed position, where's your tongue? Is it in the base or is it in the palate? Okay. And most of these patients, you find that the tongue is in the palate. And they, after you've explained the grinding, that's what we're getting to, do the grinding to them, they would come back on their follow-up visit and tell you, but I do that when I drive. I do that when I sit in front of the computer. Or I do that on the telephone. When old telephones was still in fashion, that's the way that they held it.
Yes.
And that's where that pain comes from.
Yeah.
So for very prominent public patients of mine, that has got the acute problem, it's actually quite simple to treat. Tell them, if they're in the meeting, they must consciously put their tongue between their teeth. Because then they would relax it. Because then we get back, where's your teeth? Because some people, if they think that their relaxed position is teeth in contact.
Oh, I see. Okay.
Okay. So if it's at all teeth in contact, I would immediately go to a bite plate and I would open the bite very slightly.
Okay.
Yeah.
Okay. Then with the movers,
Yeah.
okay, the important appointment for them is a week later. So I would open them, say, by 1.5 by 2 millimeters, and then I would first send them away. The first time when I come in is I grind the bite plate into a neutral position. Now here it's important when there's a locked bite or a tooth in cross bite
Yeah.
and keeping it in position.
Yeah.
So there's a lot of literature now saying occlusion has got nothing to do with
Wow.
TMD.
Yeah.
I do not agree
Yeah.
with that because there's so much problems that can occur, and they also try to say that a bite plate has got no place in TMD, and I absolutely disagree with that. So at the first point, I normally look for at least 8 points of contact between the lower jaw and the bite plate.
Okay.
So if I've got 8 points of contact, then I would send the patient home. The other thing is where I might be a little bit controversial in what I do, but you asked me what I do. I do not like the occlusal surface of the bite plate to be highly polished, because that gives your tongue something nice to function on, and if you bite close, it's nice because it's nice and soft. I wanted a little bit of a roughened surface, so I just take a fine acrylic roll and just go over with the surface, and then I send the patients away home to sleep with it for at least a week. And you cannot believe the occlusal pattern that you get when you retest it after a week. And then I make 100% sure there's not lateral interferences, and then I make sure that there is canine disclusion. So that's what I do for the second
makes
group.
complete sense. So there's a very different approach to the two
Absolutely.
to the two patients.
Yes.
And I think that's what we get wrong so often as dentists, and there's just a bite plate.
Yeah.
You know.
Yeah.
I mean, I even get patients referred to me, and then it's just, please make the patient a bite plate. Okay, but what does that mean? So, especially from the physios.
Yeah.
So if we can define those two types of patients, what else do you look at when you look at a bite plate? I know that there's some dentists that still use a soft bite plate, that some dentists use an anterior disarticulating device.
Yeah.
Then I used to do acrylic bite plates. Nowadays we use a printed material, so a resin printed material, which I really like, which has a little bit more flexibility. What is your opinion on which direction to go with the material choices?
Material choices is absolutely not an anterior displacement of a bite plate. That's just my absolute pet hate.
Yes.
Because it's called Mayo Health Plate.
Yeah.
And Mayo does not come from the Mayo Clinic. It comes from a dentist with a surname of Mayo in Australia.
Yeah.
And that is the truth.
Yeah.
So that's my pet peeve. There are some acrylic. I used to use acrylic for a very long time, and then I used the material from Germany, which was a soft hard. So on the teeth itself, it fitted softly, and then it was also an acrylic type of material that I worked a lot with, and it is satisfactory. But the resin printed materials has really blown my mind. Because of the adaptability of the patient's acceptance of it, and it's really good. My only problem, and maybe you can comment, maybe now I can get you into the chair, is how to clean that.
Yeah.
That is the
It's a good point.
because they invariably discolor, and you cannot put it in Sterident or anything like that to clean it. So
there's a material that we're using. I can't remember the name now, but I will definitely send it to you. It's a cleaning liquid that we use to clean aligners for specifically staining. So it's not the same material as the Sterident or the Correga. It's a cleaning liquid that we found that actually does clean it quite well. So I can give you the name. It helps with that staining. But the other thing that I find with the resin printed biplates is they don't last. They break.
yeah.
So I've had a conversation with my lab where with our acrylic biplates, they kind of just lost.
Yeah, I kept them for 5 years, and then after 5 years I was okay unless the dog got it.
Yes, that's an often the thing that happens. But I've now we've been using the resin printed biplates for about 3 years now, and I would say that their lifespan is about a year to 18 months.
Yeah.
I've had a better, maybe my patience has gone to my best competition, but it's not been my experience this far. I try to make the bite plates as small as possible to get it as acceptable as possible.
Yeah.
And the technician that we work actually makes a little enhancement on the canines, both of the canines. That gives it more rigid integrity, I think.
Okay, that's interesting. Okay, so
and the patients don't find it uncomfortable.
Yeah,
I actually thought
definitely.
that the patients would find it uncomfortable, but they don't.
Yeah, and that for me, I've had a couple of conversations with patients that I've treated over the years that we've moved over from an acrylic bite plate to a resin printed bite plate, and I told them that this bite plate might break, and we kind of have a discussion over cost, but for them it's much more comfortable, so they would much rather have the resin printed one, even though we're going to replace it every 18 months, which in some clenches that's just what happens. But the comfort level is just it's a given for me, and much more important for you to actually wear the bite plate. But it doesn't really help if you have a really strong acrylic bite plate that's in your drawer.
That's and then obviously I at least ask my patients to use it for 3 months, and then I would step it out if they are symptom free. Okay, if there's then an underlying problem, we will address the problem either whatever, occlusally or whatever, to get if we had used it as a diagnosis. And then I don't like to enforce my patients to always wear it for the rest of their lives. But I say keep it in the drawer. So, and I don't also just suddenly stop. So I discontinue every second day, every third day, and then we stop. And then if there's symptoms, they come back, they put it back, and then they know they've got to come for another appointment, because we have not addressed their underlying problem. And the bar on the S-curve that I was talking is lowered. And I want to know what influenced it to go lower. And most of the time it's life stresses. It's either an exam, a move, a divorce, something like that I find. And then they need us to just give them the encouragement and to take them through treatments again, and just to be objective on their pain and problems.
Oh wow. I'm really glad we are discussing bite planes and materials, because we always seem to forget that part of the multidisciplinary approach includes a technician as well, the lab technician. So what do you record for your lab technician? Do you send it? Do you do the printing yourself? Do you?
No, remember that I do surgery, so we're not digitally enhanced, although I do all my planning on digital, but I don't have a scanner. So I still take traditional impressions, but we give 2 sets at least. So my oral hygienist takes the impressions, and that gets scanned in, and from that a bite plate is made, and I still use wax as a bite registration or an elastomeric material. Depends on how difficult I find it. But with that, the oral hygienist would do everything, but the bite registration is my responsibility.
Okay.
So that I take great care to give a good bite registration.
Which is the lab that you make use of, if you feel comfortable sharing that?
It's Bobby.
Okay.
Yeah, so I use Bobby.
Yeah. Okay.
No, it's excellent.
And then your communication with patients with regards to their diagnosis. Obviously, I said that you had mentioned that it's a very, very complex disease, and obviously carrying that message across to the patient can sometimes be very difficult. Patients sometimes struggle to comprehend basic diagnoses. So what is the software that you mentioned you make use of, the video software? I've seen it.
Yeah.
It's amazing. So if you could share your secret with us, that would be great.
It's actually an anatomical video that I found in the basement of Tygerberg Hospital, and nobody was looking at it. And I made copies of it. Comes from Northern Europe University, and it describes all of the different stages of TMD. And I find that is immaculate, impressive. And I also use chairside to explain to my patients exactly where the muscles are located so that they can understand it.
Yeah.
And if they say, for instance, that they are not happy or cannot do my physiotherapy, my physiotherapist attend to them, then I have a picture of the temporalis, the masseter muscles, because that's really the important ones. And that I send along to the physiotherapist, and they must then treat those muscles. I always tell my patients, just to make it a little bit lighter, I say when I go to the hairdresser, I get frustrated because I now go to the Mediterranean, but before that I went to the normal salon, and the woman would come and they would massage you just above the temporalis muscle. And I would say, listen, 2 inches down, 2 inches down. And a lot of the physiotherapists forget how broad the temporalis really is, and they do not spend enough time on the full muscle.
Yeah.
What I've done in recently to really identify muscular TMD, is I anesthetized the temporalis implantation on the coronoid. Intraorally.
Yeah.
So you ask the patient to open, you feel the top of the coronoid, so you're quite far from your inferior alveolar, and you come across from so I sit on the left-hand side or right-hand side of the patient, and then I go laterally onto the coronoid. Okay, so I feel the coronoid.
Yeah.
And then I pull it back by 1 millimeter, and then I inject. So you feel you've got to be in the muscle itself.
Yeah.
And then I inject that, and I inject just 1/4 of an ampule. And it's amazing how many patients have immediate pain relief.
Wow.
Yeah.
So if you palpate the temporalis inside the mouth, and you're not 100% sure how much it is temporalis or it's the masseter, and you want to distinguish between the two, because the whole of the temporalis muscle, that big muscle, comes down underneath the zygomatic arch, and it only attaches on that bit of the coronoid. So how difficult is it?
Wow.
It's that big a muscle coming into this little space.
Oh,
Yeah.
wow.
So if you then anesthetize this for at least a diagnostic way,
Yeah.
it's an amazing way to eliminate that.
Oh, that's a very nice word to distinguish.
Yeah.
That makes sense.
We might possibly need to edit this out because I think you just gave some of the Botox practitioners another place to
I've actually pointed that because we did an amazing anatomy course with all the plastic surgeons, ENTs, maxillofacials together, and I actually asked Isolde I was actually telling her, but there are some quite stringent reaction from the international Botox users not to use this technique. Why? I cannot see it. They're talking about cleft lip and palate type of patients where the anatomy is wrong, but I think Isolde got the message wrong on what, because you immediately could identify what I was explaining, but she comes from the medical side, so she knows the masseter, but they haven't dissected and the temporalis out. I mean, you could immediately do that injection by just by me explaining it. But for them, it's more difficult.
Yeah, it's very interesting how the dentists have quite a unique feel when it comes to doing Botox sometimes. I mean, I think that there's some dentists that have a much better understanding of how to give Botox when it is needed than what some medical practitioners do.
Absolutely. And I don't know if you saw the lecture on ethics and scope of practice. At the moment, there is no defining scope of practice that limits you.
And then, so before we close the door on Botox, I do have one more question. What are the consequences of my initial consult with you? You obviously tell me that I need a bite plate. You quote me for the bite plate, and I think it's absolutely ridiculous. And I just go to a dentist or to a dermatologist or plastic surgeon, and I get Botox as my first line of treatment. What are the consequences of that?
The consequences is that you've had a little bit pain for the injection. There's nothing that we can do about it. I mean, that is the patient's choice. And unfortunately, there's also a lot of scrupulous people that would just inject at random. What I can tell you is the problems that I've seen in my career. And these patients, especially the psychological ones, they grab onto something. And this is one of my peers, my colleague's wife, not in the dental field, in the medical field. And she went for these injections with a general practitioner. And in the end, she lost almost all definition of the temporalis because they just injected, and she looked like a skull. She came in because all of this muscle had then, over years, had become permanently damaged. So it can be, yes, it can be aesthetically and also functional, a big problem with anterior open bites developing. The masseters being unequal and being very visible, very aesthetic problems, but functional open bite, luckily it goes past and the open bite closes itself mostly. But in severe cases, I have seen the muscle atrophy, and it is not nice to see what it looks like when Botox is misused.
And I'm assuming that's over years and years and years of use. That's not just a couple of Botox injections.
No, that's why I say, you ask what would be the problem, it's just a little pain of the injection and that's it. Because it is, that's the advantage of using the Botox. It is reversible.
Do you find that some patients have just symptomatic relief though? So what I've seen is that in acute cases, there has been patients that is just with one Botox injection just it changes their lives
Yeah.
because they might be in such acute pain. Is there a place for that?
Yes, most definitely. For acute pain, but also, the real grinders, and those that have destroyed a lot of tooth structure in the vertical,
Yes.
and you want to do a full rehab
Yeah.
Yeah.
of those
Yeah.
patients, and you need to open the bite, and with the clenches you're gonna have difficulty.
Yeah.
So what we found it out by chance. So just before, also with implants, and just before you open the bite, 48 hours before we give Botox, and it is radical
Yeah.
how the patients accept their old bite or their correct vertical dimension
Yeah.
by just that simple Botox in both of the masseters.
Yeah.
So that to me is a clear indication to use Botox maybe once.
Yeah.
Yeah.
But most of the times it has to be repeated, unfortunately, progressively over a period of time. And most of the patients do adjust their muscles, and the muscles atrophy and they have less function on it. And they're not used to biting so hard anymore, and with a bite they do well, and they tend to regress from using Botox.
Yeah.
Whilst there's another group that continuously need them, and for them you need to start writing motivational letters to the medical aid why it is necessary. And unfortunately there are that group, and they even amongst our peers and in our profession, that need that, and they do get the benefit of that in real terms and not only psychologically.
Yeah. In closing, Blackie, thank you so much for sharing your vast knowledge. It's been really insightful, and I've certainly learned one or two things.
Yeah, I'm listening to this 5 times.
Before
just my editing.
It's definitely opened up my eyes to a couple of things that I can improve on in my practice. Are there maybe a tip or two that you can give the younger dentists that find this a bit intimidating when we're looking at treating TMD patients? What tips would you give them?
The first step is time. Take your time to talk to your patient, and take your time to get to a diagnosis. And don't underestimate a patient's intelligence by giving them the knowledge of the problem and how it manifests is most probably the most important tool that we have in treating TMD. Don't jump to conclusions. Take your time, and each patient is different. So a lot of the time we want to do that filling in 15 minutes, or it must be done. You've got to have a longer term approach to the patients and listen to your patients. And it is not wrong to ask an opinion of your colleague, or in the end, if all of you can't get to a point to refer a patient further.
Yeah.
Don't put the psychological effect too quickly, because the patients really suffer from TMD, and it is a difficult thing to manage. And because there's not a lot of scientific correct consensus statements, and that is why it is difficult to treat.
Makes complete sense. So no clear protocol to really follow.
Yes.
There's no step 1, step 2,
Yeah.
step 3.
Yeah.
So if in doubt, rather refer to someone.
Yeah,
that
it this makes the Swiss mad, because they want 1, 2, 3,
Yes.
and
Yeah.
then it must be 4.
Yeah.
And unfortunately, the best thing that you can give your patient is your time and your knowledge of anatomy.
Yeah, that sounds like a good approach.
Yeah. Wow. Thank you so much, Blackie. Thank you.
Yeah.
That was great. Thank you so much. Yeah.
Thank you very much for coming, and
Yeah.
it's a real honor for me to have you guys here. And I can't believe that I'm the older one, but I am now the older generation.
Yeah.
It's been amazing. Thanks, Blackie. Thank you so much for joining us today on the Dental Tutors podcast.
Please visit, like, comment, and subscribe on our platforms below.
Or if you have any questions, please send us an email.
Until next time, have a great day further.